Good evening to all the viewers. This is Batul from IGCP, and I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. Sir needs no introduction, but it's my pleasure and honor to introduce him at our platform. He is none other than a very renowned nephrologist, Dr. Ratan Jha, sir. Sir is MD, DM, DNB, GTCD, gold medalist, FISN, senior nephrologist and transplant physician at Care Hospitals Outpatient Center, Banjara Hills, Hyderabad. With the help of Sir, we'll be taking a close look on today's topic, which is resistant hypertension. Now, without taking much time and without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his talk to begin. Sir, over to you.
Thank you. Good evening, friends. Today I am going to talk to you about a very common and complex topic, resistant hypertension, that we see as a nephrologist in our day-to-day practice quite commonly. We are going to highlight certain points which many times gets missed, leading to a kind of unfavorable outcome. As a nephrologist, we believe that for hypertension, kidney is the culprit even in the absence of kidney disease. And this statement has been made by a kind of world-renowned the physician, Dr. Bakris, who has multiple publications in the context of hypertension. He believes, and we all believe, that hypertension has its origin in the kidney, even in cases of essential hypertension. And this is based on the following simple observation: that kidney malfunction precedes hypertension. Like microalbuminuria, hypertension goes with the kidney when we do a kidney transplant in a person who is not hypertensive before, and getting a kidney from a hypertensive donor becomes hypertensive. Low birth weight, which is associated with low nephron mass, predisposes to hypertension. These simple observations suggest that hypertension is the culprit even in the absence of kidney disease, like in the so-called essential hypertension. The definition of resistant hypertension has to be again re-looked at. That what is the definition at this moment? The blood pressure, when it remains above the goal of 140/90 for in general, or 130/80 for people who are having diabetes or chronic kidney disease, in spite of concurrent use of 3 antihypertensive agents of different class, will be categorized as resistant hypertension. When we are talking about 3 agents, at least one of these agents should be a diuretic, and all agents should be prescribed at an optimal dose and or amounts. So when we talk about 3 drugs, the commonest common combination that we refer to is blockade of the renin-angiotensin system, use of a calcium channel blocker, and using a diuretic which is appropriate for the GFR. So when these 3 drugs are prescribed and the BP is not getting to the goal of 140/90 in general, or 130/80 for people who are having diabetes or chronic kidney disease, it is defined as resistant hypertension. So if we look at this entity, there are few terms which many times will look confusing. Uncontrolled hypertension is a common problem which results in substantial cardiovascular morbidity and mortality. By the time we talk about cardiovascular morbidity and mortality, we mean left ventricular failure, left ventricular hypertrophy, and a coronary artery disease. So any hypertension which is not controlled, even if it is not in the so-called resistant hypertension category, is associated with increased mortality. Resistant hypertension, which is defined as 3 or more drugs in an appropriate dose, is said to exist in the literature to the tune of 7% to 9%. And it requires a tailored approach to get to the goal and reduce the morbidity. Common coexisting factors which contributes to the cause of resistant hypertension are the comorbidities like diabetes, associated obesity, coronary artery disease, heart failure, and chronic kidney disease. They run in association with resistant hypertension, and this is a kind of common kind of cocktail of risk factors which produces the increased risk of mortality. So one of the things which have been highlighted in the recent literature is that we should not only look at the pharmacological therapy, but also focus on the lifestyle issues which may contribute to such resistant hypertension, like advocating low sodium diet, adequate sleep, that is minimum 6 to 8 hours of sleep, and an appropriate exercise for the patient. And this this focus is quite effective in bringing down the resistant hypertension to a control kind of resistant hypertension. So the resistant hypertension, which is a common entity and with a reported the literature prevalence of 7 to 9%, has been reported to increase in its prevalence with the recent cutoffs which are advocated in US, that is BP 130 by 80 or below, which will mean that 16% of people who are being treated are getting into a zone of resistant hypertension. And it has been reported that in certain populations like chronic kidney disease, the late stages, 40% of patients at least comes under the category of resistant hypertension because of various other associated problems of chronic kidney disease like volume overload and dietary indiscretion, etc., and the use of erythropoietin and other drugs. So resistant hypertension, which is seen or categorized, could be a real resistant hypertension or an apparent resistant hypertension, which is also referred to as pseudo-resistant hypertension, where the person looks to be resistant, but is not the true resistant because of various factors which we will discuss in subsequent slide. So whatever be the association, this is associated with increased incidence and prevalence of target organ damage and increased risk of cardiovascular risk and mortality. It has been noted that suboptimal medical regimen that is employed and the lifestyle issues which are ignored could be the contributing factor for resistant hypertension. We must exclude, before we make a diagnosis of resistant hypertension, a pseudo-hypertension, a white coat effect that will be discussed in the subsequent slide. There is a term called controlled but resistant hypertension. That is a person who requires more than 3 drugs to less than 5 drugs, and BP is controlled, is called controlled resistant hypertension, which is also a new category, which suggests that person has to be continued to be on focus so that they do not lose that control and get into the risk of cardiovascular death. And in US, in one of the studies which was published way back 5 years back, showed that 20% of US population has resistant hypertension of true nature. 2/3 of them ultimately get to the goal, that is called control resistant hypertension, though 1/3 may remain uncontrolled, and 3% of the patients only in this category will have a kind of refractory hypertension, which is requiring 5 or more drugs. So this is a new nomenclature where we talk about one more category, which is a refractory hypertension. The synonyms which are often used in literature for resistant hypertension are difficult to control hypertension and a special subcategory of refractory hypertension requiring more than 5 drugs. So this is a slide which is showing very clearly how we should look at hypertension. If BP is below 140 by 90 on treatment, it is called controlled hypertension. But if BP remains more than 140 by 90, it is uncontrolled hypertension. The controlled hypertension could be of 2 types: controlled hypertension which requires less than 2 drugs, or controlled resistant hypertension which requires 3 or more drugs. The uncontrolled hypertension is a hypertension where 2 drugs have failed to control the blood pressure to the goal, and when it is more than 3 or 4 drugs, it is called a resistant hypertension. The moment you require more than 5 drugs, it is a refractory hypertension, which is either controlled or uncontrolled. So this is a new way to define the categories of hypertension to look at what can be done additionally. So it has been reported in literature that the refractory hypertension are usually not fluid dependent, and it is associated with high sympathetic tone and low BNP or brain natriuretic peptide, that is, evidence of volume overload. It is a kind of dry hypertension. It is more common in young females. Resistant hypertension, on the contrary, are because of fluid accumulation of fluid dependent hypertension with low renin and high brain natriuretic peptide that we see in patients of chronic kidney disease. So this is a conceptual framework to decide which category of patient we are trying to look at and what are the drugs that we can give. So a dry hypertension is a resistant hypertension in general, And the wet hypertension, resistant hypertension in general, and dry hypertension, usually refractory hypertension, in the category of difficult to control hypertension. But when we talk about the hypertension control, one has to understand the values which has recently changed, and we try to follow the International Society of Hypertension Guideline 2020, where the blood pressure was defined as a normal blood pressure when the BP is less than 130/85 in the office. High normally between 130 to 39, and 85 to 89 is the high normal blood pressure. Beyond that is grade 1 hypertension 140 to 60, 90 to 99, and grade 2 is more than 160 to 100. Earlier, grade 3 and 4 hypertension have been deleted from the list of hypertension because those are very uncommon category. The terms optimal, pre-hypertension, elevated blood pressure, etc. has been removed from the classification of this ISS guidelines. But these are the high blood pressure which we check in the office. It is different from the home blood pressure monitoring and the ABPM. Like this is a slide which shows that the cutoff values for office BP for making a diagnosis of hypertension 140/90, but the ambulatory BP 24 hours record, if it is more than 130/80, it is suggestive of hypertension. Daytime blood pressure 135/85 and nighttime 120/70. If it's exceeded, it is called hypertension based on the ABPM criteria. Home BP monitoring is in between, that is between the ambulatory BP monitoring and office BP monitoring. The 135/85 and above will be considered as a hypertension. So we have to be familiar with the cutoffs and the situation in which we are checking the blood pressure with which gadget. So the guideline of the recent times have become more liberal to recommend the use of ABPM, that is the ambulatory BP monitoring, because it not only confirms hypertension with clarity, it detects white coat hypertension and a mass hypertension and the effect of treatment of hypertension and to titrate the dose. It hasn't found that those who are having a kind of hypertension which is more nocturnal, which is not 24 hours control, will have more risk of hypertension mediated organ damage, which can only be identified by ABPM or ambulatory BP monitoring. So we need to use this tool to diagnose or label a patient to have resistant hypertension of true nature. This is the way the reports of 24-hour BP monitoring comes, where we have a graph which gives a kind of 24 hours record, where we can see in this patient that BP is not controlled throughout, and even during the night time the blood pressure is high. So this means the person has a 24 hours BP is on the higher side, and this person will have to be treated appropriately to control not only the daytime blood pressure but the nighttime blood pressure. So the diagnosis of hypertension on 24 hours record is 130 and 80 and above, while the daytime blood pressure 135/85 is a hypertension. There are many other parameters which are shown in the slide, like the diurnal index or morning surge, which we will discuss in subsequent slide. So the beauty of using the different kind of gadgets are shown in the slide, that we can pick up both the white coat effect of hypertension with the ABPM as well as the home BP monitoring, as well as the masked hypertension. The threshold for diagnosis of hypertension is shown in the slide, that the threshold for ABPM is different, that is values are lesser than the office blood pressure by 5 millimeter of systolic and diastolic in daytime, and 10 millimeter or 20 millimeter by 20 millimeter diastolic at the night time. And 24 hour record should be not more than 130/80. So we need to be familiar with the ABPM this reporting. The values are different. There are certain ways to classify hypertension at night time. The dippers, that is the blood pressure should dip normally by 10 to 20%, which is automatically calculated by the ABPM machine. While those who have no dipping or reverse dipping, that is BP goes up in the night, or extreme dipping is when the value is processed 0% or 20% as shown in the slide. So this is also additional information that we can get the difficult to control blood pressure or resistant hypertension by use of ABPM, and hence it should be a tool to be utilized whenever it is available. So that there are for certain terminologies which are shown in the slide, that when we get an ABPM report, we look at 24 hour BP, daytime BP or active period BP, nighttime BP or or passive period BP, diurnal index or dipping pattern that is automatically shown in the report, morning surge, because normally the BP goes over the baseline in the morning hours, and that is also associated with increased risk, and standard deviation, that is the BP variability, which is automatically calculated by the machine. So like this record where what we see, the blood pressure in the daytime is totally controlled, but in the night time, instead of dipping, the blood pressure has gone up, which is called the reverse dipping. And this is associated with PND and increased kind of hospitalization and mortality. And this can only be picked up by the ABPM. So this is a patient which is not controlled so far, hypertension is concerned, and this is a reverse dipping. So nocturnal hypertension is also a part of the care in a patient of resistant hypertension, and we have to know that there is diurnal variation. Usually BP rises in the morning hours, peaks in the midday, drops in the late afternoon, and slowly dips in the night. And any person who has a nocturnal hypertension will have increased risk of LVH, heart failure, and other kind of stroke incidents in the night time. The patient characteristics which have been associated with resistant hypertension in general are the high baseline blood pressure. That is, most of the time BP will be on the higher side. They are old, they are obese, they are having excessive salt intake. In general, they may be associated with chronic kidney disease, diabetes, echo-meso left ventricular hypertrophy, and they are usually female. So these are general characteristics of resistant hypertension, which we'll discuss in the subsequent slide. But before we make a diagnosis of resistant hypertension, we must look at, is there any possibility of pseudo-resistance? The term pseudo-resistance means it's not true resistance. It is because of poor adherence to the prescribed medication or the diet, that is, they are not taking lesser amount of salt, inaccurate blood pressure measurement, which could be because of the sizes of the cuff, if it is not appropriate for the person's body mass index, this will give us higher record. And the white coat effect or white coat hypertension, which can only be detected by home BP monitoring or a ABP. So these are the things which have to be first of all excluded before we say that it is a true resistant hypertension. So a patient who has been given a level of resistant hypertension based on the standard criteria, first thing is we have to confirm that he's getting an appropriate treatment, which we'll discuss in subsequent slide. We always need to look at, is there any secondary causes that needs to be evaluated, and we have to document, is there any evidence of target organ damage like left ventricular hypertrophy, diabetic retinopathy, or chronic kidney disease, which will require referral to the specialist. But many of the times you will find that there could be no cause which is apparent, secondary cause, other than the lifestyle issues, and there are no target organ damage, and this is a case of essential hypertension to be tackled with appropriate advice. The secondary causes of resistant hypertension, which are common, though the big list is there. The 4 common causes are obstructive sleep apnea, which is usually associated with obesity, renal parenchymal disease of any type, mostly a glomerular disease, primary hyperaldosteronism, which may be associated with adenoma or hyperplasia, and the renal artery stenosis. So these are the only 4 common causes of resistant hypertension. So the uncommon causes could occasionally be seen in a center which is catering to a large population of resistant hypertension, like pheochromocytoma, Cushing's disease, hyperparathyroidism or thyroidism, also aortic coaptation, and occasional intracranial tumor. So these are the things which have to be evaluated on the select situation as per the appropriate case. This is just a kind of MRI image to show that what is adenoma. This is a 3 centimeter adenoma at the top of the left kidney. The child whose BP was difficult to control and had presented with failure to thrive with recurrent vomiting, and the BP was set quite high and required more than 3 drugs to control blood pressure. Subsequent to removal of this adenomatous adrenal gland, the BP got easily controlled, and patient is doing well in the follow-up. Patient presented with hypokalemia with severe hypertension. Hyperaldosteronism in general is regarded as the important secondary cause of hypertension, particularly in the context of discrete adenoma, which has got a low incidence, but adrenal hyperplasia, which is associated with resistant hypertension is reported to be more common. It is said to be more prevalent with a resistance with a reported prevalence of as high as 20%. This is picked up by a value of this plasma aldosterone concentration and plasma renin, the assay ratio, and any value of plasma aldosterone more than 15 nanogram and high PSC by PRA ratio of 20 to 30 is consistent with the diagnosis of hyperaldosteronism. Drugs like ACE inhibitor, ARB, and MRA, which may be getting prescribed, has to be temporarily withheld to make the correct diagnosis of hyperaldosteronism. Hyperaldosteronism these days are often normocaloric, unlike the patient that I presented, which was having a kind of potassium in the lower side of 2 milliequivalent. Prevalence may be overestimated by selection bias because the centers which are looking at routinely will get a higher kind of prevalence. It has been, however, noted to be associated more with obesity and OSA, where it has been postulated that oxidized fatty acid derivatives common in obesity may stimulate the aldosterone secretion with aldosterone hyperplasia, with the adrenal hyperplasia, where we will not get usually adenoma, and the plasma aldosterone concentration is increased in such patients who are having OSA. Benefits of mineralocorticoid blockade has been noted in such patients who are having resistant hypertension with obesity and hyperaldosteronism. Obesity, therefore, has been reported to have higher prevalence of resistant hypertension and is associated with insulin resistance, obstructive sleep apnea, and hyperaldosteronism, all of which can be contributing to severe hypertension, which is resistant to 3 drugs. And it has been noted that lowering the body weight by appropriate diet, exercise, and drugs may have a profound effect on the BP control beside the pharmacological therapies. So, coming back to the topic, how do we approach a patient with resistant hypertension? We need to have a valid BP measurement, including an ambulatory BP monitoring, which will exclude the bias. We have to look at it. There should be absence of drugs or items which can increase blood pressure or drugs which can antagonize the antihypertensive effect of drugs. Non-adherence to the drugs has to be excluded. That person who has been prescribed 3 drugs is taking the drug in right dose. Comorbid conditions which has to be looked at, particularly obesity, diabetes, obstructive sleep apnea. Secondary hypertension has to be also looked at. Is there a cause to be evaluated? And then we have to prescribe both the non-pharmacological intervention and pharmacological intervention. And this will be the approach. The first thing is to have a valid BP measurement. And in this regard, we have to look at what are the guidelines which are recommended. It is these days, the recent guidelines recommend that manual BP measurement should be replaced, which we commonly do. An automated electronic sphygmomanometer, which is tested properly. Mercury manometer and Android apparatus, which are oscillatory method to check the BP, is no longer preferred. Semi-automated BP monitoring by the oscillometry method should be used commonly, and is a common practice these days in most of the office setting. Automated blood pressure, which is also preferred, where multiple oscillatory reading is taken, which is reproducible, is the way forward. In situation where we are suspecting a kind of pseudo-hypertension, the intra-arterial blood pressure could be checked where the arteries are palpable, but it is not commonly done. So the algorithm revisited evaluation resistant hypertension. First of all, we confirm that the treatment resistance, that the BP is higher, more than 140 by 90 or 130 by 80 by repeated measurement, including ABPM. Exclude the pseudo-resistance, that patient is adherent to the diet and drugs. And we have looked at the home work and ambulatory BP reading, exclude the white coat effect. One has to understand that the term pseudo-hypertension is different from pseudo-resistance, that we will discuss in the subsequent slide. So, pseudo component has to be excluded, compliance has to be verified, and white coat effect has to be excluded by the ABPM that we talked about. The pseudo-hypertension is a kind of hypertension where, because of poor arterial compliance caused by advanced atherosclerosis or vascular calcification, we get a very high systolic blood pressure. Osler's maneuver is said to be an important clinical sign to suggest the possibility of pseudo-hypertension, where we find the brachial artery or radial arteries are distal to the fully inflated cuff is palpable. Intra-arterial monitoring will be required in such situation to exclude this possibility, but it is not a practical thing which we do not do commonly. Evaluation of hypertension, therefore, the first step is identify and reverse the contributing lifestyle factor like obesity, physical inactivity, high salt diet, or low fiber diet. Discontinue or minimize the interfering substances which are dietary pills, decongestants, oral contraceptives, ephedrine in the nasal drop, non-steroidal anti-inflammatory drugs. So these are the first step after the diagnosis of resistant hypertension has been confirmed. We should screen for the secondary causes of hypertension, which is the second step, if it is appropriate, by looking at the obstructive sleep apnea, snoring, witnessed apnea, excessive daytime sleepiness, primary aldosteronism, which is basically picked up by elevated aldosterone level or aldosterone to renin ratio, chronic kidney disease, where we look at the kidney GFR and the albuminuria to make a diagnosis. Resistant hypertension is usually seen when the GFR has gone below 30. Renal artery stenosis has to be particularly looked at in young females, a person who has known atherosclerotic disease or sudden worsening renal function with ACE inhibitors. Pheochromocytoma, where the BP is high, with palpitation, diaphoresis, headache, etc. in a young person. Cushing disease, where you have appropriate phenotype of moon feces, central obesity. And aortic coaptation, where differential blood pressure and femoral pulse or systolic breathing will be heard. So these are the things which have to be looked into to decide how much to investigate at the second step. This is a patient that we saw recently where a young female was presented with difficult to control hypertension after occurrence of stroke in the past. What we see on the left side, on the right side, is the above the kidney, there is a kind of big mass which is around more than 5 centimeter in size, which was diagnosed to be a kind of pheochromocytoma, which was operated, and patient's blood pressure became better controlled. It was not that person was not requiring antihypertensive drug after surgery, but the BP was controlled with 2 drugs. So the evaluation, once we have evaluated the resistant hypertension by looking at all the factors, that we come to the third step of the treatment. Treatment will mean a pharmacological treatment where we have to maximize the diuretic therapy, including possible addition of MRAs, combine agents with different mechanism of action, and you may have to use loop diuretic if GFR is below 30, and we may have to add on other drugs to control the blood pressure. And if person is not getting controlled by 3 to 5 drugs for more than 6 months, and we are not sure about the secondary causes, we need to refer to a specialist. The non-pharmacological recommendation in general are weight loss, regular exercise, that is at least 30 minutes of walk most of the days of the week, low dietary salt intake, that is less than 100 milligrams per day of sodium, that means less than 1 teaspoon of salt, moderate alcohol ingestion, no more than 2 drinks, ingestion of low-fat, high-fiber diet, and treat the obstructive sleep apnea present with the appropriate gadget or CPAP machine. The recommended combination of BP loading drugs is shown in the slide, and that is usually referred to as ABCDE, that is A for angiotensin or ACE inhibitor, angiotensin receptor blockers, B for beta blockers, C for calcium channel blockers, D for diuretics, and E is the remaining, that is alpha blockers and vasodilators like hydralazine, minoxidil, etc. So the red lines are basically the preferred combination. This is a kind of hypertension guideline slide taken from the European Society of Cardiology. They have referred that this would be the algorithm, that ACE or ARB with calcium channel block or diuretic as the first line therapy. That is 2 drugs, then 3 drugs, the ACE, ARB, calcium channel block, and diuretic. And when this step 2 is not sufficient to control blood pressure, then that is called resistant hypertension, where the triple drug combination of ACE, ARB, CCB, and diuretic fail to control it, and where we may add spironolactone if appropriate, if there is no contraindication, or we may have to refer to a specialist to explore the other possibilities. Other drugs can be added based on the need. Beta blocker could be one of the drugs, though other drugs like the vasodilators, alpha blockers, or central sympathetic drugs can also be used. So after the first three drugs, the remaining drug sequence is not a kind of universally agreed sequence. The fourth drug could be spironolactone. Certain reports suggest that in the developing world, clonidine can be a good drug to control resistant hypertension, and a beta blocker can be added in place of clonidine if person's heart rate is more. Spironolactone is not a common drug that we prescribe in the late stage of kidney disease with hyperkalemia. The fifth drug could be an alpha blocker like doxazosin or even the prazosin, or a vasodilator like hydralazine or minoxidil. CPAP, weight loss, and sleep hygiene should be a kind of therapy which needs to be focused in such situation where the person is obese. And it is generally said that when a person requires more than 4 drugs, it is better to refer to a specialist to look at the other causes of hypertension which needs to be excluded. So this is a kind of textbook slide that steps of managing patient-resistant hypertension. Step 1 is basically excluding other causes of hypertension, that is secondary causes, ensure low sodium diet, optimize the 3-drug regimen that we talked about, the RAS blocker, calcium channel blocker, and diuretic. And if it is not to get to the goal, then diuretic can be changed from a short-acting diuretic to long-acting diuretic like chlorthalidone or indapamide. And BP is still not controlled, one can add spironolactone. That is step 3, which is a kind of stage for resistant hypertension diagnosis. And it's still BP not getting controlled, then based on the heart rate, if it is less than 70, a beta blocker can be added, like carvedilol or levetiracetam, or any other drug which like alpha blocker can be also added. If BP is still not getting control, one may add hydralazine in the right dose of 25 milligrams 3 times a day, and we may need to add isosabardinitrate if the person has a kind of ischemic heart disease associated. BP is still not getting control. Minoxidil is the last line drug that can be added, but we need to refer to a specialist to see why the BP is not getting controlled. So these are the steps which are mentioned in the guidelines and then the textbook. One of the therapies which is talked about quite commonly these days is the denervation therapy, or the baroreceptor activation therapy, or BAT therapy, which are called device-based therapies. But one has to realize that this device-based therapies for hypertension is still a kind of experimental therapy, and is not recommended for routine treatment of resistant hypertension unless it is being done in the clinical context of randomized controlled trials, because the safety and efficacy is still not 100% confirmed. But the recent reports about the renal denervation in the treatment of resistant hypertension is shown that renal denervation is a catheter-based intervention that targets and ablates the sympathetic renal nerve to treat hypertension. Radio frequency renal denervation and ultrasound-based probe renal denervation are 2 methods studied as a modality in the United States. Multiple trials have demonstrated that it is safe, efficacious, and durable in the context of renal denervation with resistant hypertension for patients both on and off the medical therapy, but still it is far from clear whether this is recommended for patients who fail to get to the goal with more than 3 or 4 drugs. So at this point of time, renal denervation is still an experimental therapy. The newer drugs for resistant hypertension is shown in the slide. They are combined this A and B endothelin antagonists like aprocitentan has been found to be an emerging drug for treating resistant hypertension. Stat, which was the aminopeptidase A inhibitor, which is centrally acting at the RAS system, was initially thought to be a good drug, but phase 3 trials have failed to show any extra benefit. Baxdrostat, which is an aldosterone synthase inhibitor, is now being explored as an important drug to treat resistant hypertension, and the initial results are encouraging. Sparsentan, which is a drug which is both a kind of renin-angiotensin blocker as well as endothelial antagonist, though not listed as a drug for resistant hypertension, looks promising when it is available to be used for indications like IgA nephropathy, where the drug has been found to be effective. So the approach to resistant hypertension from the cardiological and the nephrological standpoint, as per the World Authority like Buckley, is shown as follows. Then in step one, besides the lifestyle kind of intervention that we talked about, that is less salt, 6 hours of uninterrupted sleep, weight loss and physical activity, decreased alcohol consumption, diuretic dose, a diuretic appropriate should be used if the GFR is below 30. Then loop diuretic can be used, or a long-acting drug like chlorothalidate to be used, or indapamide, not hydrochlorothiazide. Renin-angiotensin system blockade, the best drug as per him is a long-acting ARBs like azlisartan, telmisartan, olmesartan, or irbesartan, but not losartan. And if person has a heart failure with a reduced ejection fraction, to use ARNI in place of the ARBs. If person is getting multiple drugs, BP is not get to the goal, at least those should be such that there should be at least one drug in the evening time to control the morning BP surge. And frequent follow-up is required either in person or virtually to change the treatment. Calcium channel blocker, particularly long-acting calcium channel blocker like amlodipine, should be in combination with this diuretic and RAS blocker. If the BP is not controlled at the first step, he recommends that add a mineralocorticoid receptor antagonist, because the pathway to spironolactone was found to be quite useful. And if a person is having a kind of kidney disease with diabetic kidney disease, finerenone could be used in place of spironolactone with a similar kind of benefit. He is recommended that when you are treating hypertension, one should also consider the impact of adding SGLT2 inhibitor in the context of diabetes and kidney disease, because it has been found to have some additional pleiotropic benefit, including BP reduction. So in step 2, adding SGLT2 inhibitor after MRA could be a way to treat not only hypertension but other comorbidities. Step 3 is that if BP not getting control, step 3 is to focus on the heart rate. That is, if it is hyperadrenergic, excess sympathetic activity, then we should try to target the ventricular rate to 50 to 70, and by using drugs like beta blockers, non-dihydropiridine calcium channel blocker, or centrally acting sympatholytics. Avoid drugs like non-dihydropiridine blockers if the heart failure reduced ejection fraction is there. Step 3. Step 4 is an addition of vasodilator drugs like hydrologine, if with azoxybate dinitrate, if the person has heart failure with reduced ejection fraction. But one can use even alpha blockers like doxazocine or prazosin if the person is not having a reduced ejection fraction. And even the minoxidil can be used, but we should refer at this step 4 to a specialist to decide whether a renal denervation therapy can be a way forward in such patients who are not getting to the goal and have to be included in trials. So to conclude, the proper BP measurement, modifiable lifestyle measures, avoiding drugs which may antagonize the effect of antihypertensive, treating the comorbid conditions effectively, including use of SGLT2 inhibitors and MRAs, excluding secondary hypertension as may be appropriate, is the way to treat resistant hypertension. Non-pharmacological as well as pharmacological interventions have to be done together to get to the goal. Thank you.
Thank you so much, sir. I am posting the questions in the chat box that you can answer the questions from there.
Okay. Okay. Should I answer the question? Is it listed in the when is hypertension considered resistant in dialysis patients?
Yes, sir, you can answer the question.
The diagnosis of resistant hypertension even in dialysis will be same, but checking the blood pressure just after hemodialysis may not be the right kind of reflection on blood pressure, it is said that the BP should be checked a day after at home to decide whether blood pressure is in the right range or not. Most of the patients who are having a kind of difficult to control hypertension, which is resistant hypertension, are because of the volume overload and poor kind of dietary management, particularly taking excessive salt and not adhering to water restriction. So you will find that this is a difficult area where the blood pressure is variable at different times, including pre-dialysis and post-dialysis. And to get the right blood pressure, we need to check the BP 24 hours after the dialysis, which are hemodialysis we talk about. But in the case of peritoneal dialysis, any day, any time is same, because it is a slow dialysis where BP fluctuations are less, and the definition of hypertension will be same, 140/90 and above for making a diagnosis. But most of the patients are diabetics and CKD, where 130/80 is a cutoff. But we hardly get to that kind of cutoff in patients who are having difficult to control hypertension. They remain poorly controlled, and because of that, many times they have increasing cardiovascular morbidity and mortality and hospitalization. The second question that is there in the chat box is, how is resistant hypertension treated in CKD patient? The approach to therapy for chronic kidney disease patient with resistant hypertension is same as those who are not having chronic kidney disease. The philosophy is same, because most of the patients who are having chronic kidney with hypertension is because of volume and salt excess, sympathetic overactivity, and excess activity of renin-angiotensin system. So we require a combination of drugs, and most of the patients require 3 to 5 drugs to control the blood pressure with adequate kind of dialysis in case the person is having stage 5 kidney disease. The third question is effect of renal denervation in resistant hypertension after medication escalation. This is an area of trials. There are conflicting reports about the renal denervation therapy. The Simplicity 1, 2, and 3 trial, and few more trials have suggested that there is a role for doing a renal denervation therapy based on the radio frequency ablation or ultrasound based ablation, but this has to be done at a center with having an expertise in this field, and this is still a part of trial. So there is no final word on renal denervation therapy in resistant hypertension. It is a promising therapy, but we need to wait for some more time to decide this is going to be a long-lasting benefit.
Thank you so much, sir. Thank you for answering the questions and for putting up such wonderful insights upon the topic that you have shared with our doctors. We hope that this is definitely going to help them in their daily clinical practices. So thank you so much for your wonderful inputs about the topic, sir. With all your last comments, sir, we can conclude the session here for today.
Thank you.
Thank you, sir.
Thank you.